Hello everyone, welcome back to our channel. Today we're diving into a crucial topic, rheumatic endocarditis. As always, don't forget to like, share and subscribe to our channel and stay with us till the end. Rheumatic fever, which often affects school-age children, it can develop after an episode of group A beta hemolytic streptococcal pharyngitis, commonly known as strep throat. If rheumatic fever isn't treated promptly, it can lead to rheumatic heart disease. This is evidenced by a new heart murmur, cardiomegaly, pericarditis, and even heart failure. So, treating strep throat with antibiotics is essential to prevent rheumatic fever. Streptococcus spreads through direct contact with oral or respiratory secretions. Factors like overcrowding, poor hygiene, and lower socioeconomic status can predispose all individuals to rheumatic fever. Although the incidence has decreased in developed countries, it's still a concern because infections can go unrecognized. Now, let's talk about the signs and symptoms of streptococcal pharyngitis, which include 1. Fever, 2. Chills, 3. Sore throat that comes on suddenly and can cause severe pain when swallowing, 4. Diffuse redness of the throat with exudate on the oropharynx, 5. Petechiae on the roof of the mouth, 6. Enlarged and tender lymph nodes, 7. Abdominal pain, more common in children, 8. Acute sinusitis and acute otitis media, and lastly 9. A sandpaper-like rash. If you notice these symptoms, a throat culture is necessary for an accurate diagnosis. Patients with a positive throat culture must adhere to the prescribed antibiotic treatment, usually penicillin, to minimize the risk of developing rheumatic fever and subsequent rheumatic heart disease. Moving on to infective endocarditis. This is a microbial infection of the endothelial surface of the heart. It often develops in people with prosthetic heart valves, cardiac devices, or structural cardiac defects. It's more common in older adults due to degenerative or calcific valve lesions and reduced immunologic response. Staphylococcal endocarditis infections of valves on the right side of the heart are common among IV drug abusers. Hospital-acquired infective endocarditis often occurs in patients with debilitating disease indwelling catheters or those receiving hemodialysis or prolonged IV therapy. Invasive procedures involving mucosal surfaces can cause bacteremia, which can lead to bacterial endocarditis in patients with cardiac defects or implanted devices. Bacteremia can also result from IV drug abuse, body piercing, branding, and tattooing. Other risk factors for infective endocarditis include 1. Prosthetic cardiac valves or material used for valve repair, 2. Implanted cardiac devices, 3. History of bacterial endocarditis, 4. Congenital heart disease, 5. Cardiac transplant recipients with valvopathy, 6. IV drug abuse, 7. Body piercing, branding, and tattooing, and lastly 8. Hemodialysis. Now, let's dive into pathophysiology. A deformity or injury of the endocardium leads to the accumulation of fibrin and platelets, forming a clot. Infectious organisms, usually staphylococci or streptococci, invade this clot and the endocardial lesion. Other microorganisms like fungi and rickettsia can also be involved. These infections result in vegetations on the endocardium, which can embolize to the other tissues. As the clot expands, the infecting organism gets covered by new clot, hiding it from the body's defenses. This infection can erode through the endocardium into underlying structures, causing tears or deformities of valve leaflets, dehiscence of prosthetic valves, or mural abscesses. The onset of infective endocarditis is usually insidious. Symptoms develop from the toxic effects of the infection, destruction of heart valves, and embolization of vegetative fragments. Systemic emboli are more common with left-sided heart infective endocarditis, while pulmonary emboli may occur with right-sided heart infective endocarditis. Clinical manifestations include fever and heart murmur. Fever may be intermittent or absent, especially in patients on antibiotics or corticosteroids, older adults, and those with heart failure or kidney injury. A heart murmur may develop over time, indicating progressive damage. Other symptoms include clusters of petechiae, oscillar nodes, Janeway lesions, rough spots, and splinter hemorrhages, cardiomegaly, heart failure, tachycardia, or splenomegaly may also occur. Central nervous system manifestations include headache, transient cerebral ischemia, and strokes. Heart failure from valve leaflet perforation, cordial rupture, or vegetations can indicate a poor prognosis. Valvular stenosis, myocardial damage, and mycotic aneurysms are potential complications, and atrioventricular blocks may signal a valve ring abscesses. For assessment and diagnosis, walk symptoms like malaise, anorexia, weight loss, cough, and back and joint pain may be mistaken from influenza. A definitive diagnosis is made when microorganisms are found in blood cultures or vegetations. At least 2 sets of blood cultures from different sites should be obtained before administering antimicrobials. Elevated white BC counts, anemia, positive rheumatoid factor, and elevated ESR or C-reactive protein may be present. And echocardiography can help diagnose by showing masses on valves or supporting structures, and TEE is superior for assessing vegetations and complications. Now let's talk about prevention. Although rare, bacterial endocarditis can be life-threatening. Primary prevention is key for high-risk patients such as those with previous infective endocarditis, prosthetic heart valves, cardiac transplant patients with valve regurgitation, and some congenital heart disease patients. Antibiotic prophylaxis is recommended for high-risk patients before and sometimes after dental procedures involving manipulation of gingival tissue or perforation of oral mucosa. However, it's not recommended for non-dental procedures anymore. The type of antibiotic used varies with the procedure and risk level. Typically, patients take 2 grams of amoxicillin orally 1 hour before the procedure. Alternatives for penicillin allergic patients include clindamycin, cephalexin, cefazolin, and ceftriaxone, azithromycin, or clarithromycin. Good oral hygiene is equally important. Poor dental hygiene can lead to bacteremia, especially during dental procedures. Regular professional and personal oral care can reduce this risk. Personal care includes brushing teeth, gums, tongue, and oral mucosa twice a day, and using antiseptic mouthwash. Patients should avoid using toothpicks, nail biting, body piercing, branding, and tattooing, and female patients are advised against using intrauterine devices or IUDs. Those with substance abuse histories should seek addiction treatment. and any fever lasting more than 7 days should be reported to a primary provider. Increased vigilance is needed for patients with IV catheters and during invasive procedures. Nurses must ensure meticulous hand hygiene, site preparation, and aseptic technique, and all devices should be removed as soon as they are no longer needed. That's a wrap on first part of rheumatic endocarditis. If you found this information helpful, don't forget to like, share, and subscribe to our channel, and stay healthy, stay informed.